Right, good morning everybody and welcome to the November board meeting of the CQC. We have an apology from our Chief Executive, Sir David Byrne, who is in New Zealand. Otherwise I think we are all here. Are there any declarations of interest that anybody needs to make? Okay, good. We have the minutes of the meeting of the 18th of October. Are they a true and accurate record of everything we said? Thank you. On the action log, there is one item that says it's completed, and I would respectfully suggest it should remain on the action log because it's the action that has been agreed is it's provisionally included in an RGC meeting in January. But I think until that's happened, it should remain on the action log. Otherwise, if it doesn't happen, we will lose sight of it. So if people are happy, we'll just amend the log for the future. Is there anything else arising that anybody wanted to raise? Okay, good. So we move to our first substantive item, and very big welcome, Henrietta, to you. Really delighted you're here today. I'm really pleased with, from my perspective, the work you've been doing. So thank you for both the work and for coming today. And the floor is yours. You do need to turn the microphone on. Sorry.
Yeah, thank you very much, Chair. And really, I'm delighted to present to you the first annual report of the National Guardian's Office. And you have the very first copies of the hard copy here for the board, because it's published today. And this is not just to talk about the work that my office has been doing, but really to highlight the work that's been happening across England, particularly at regional and also at trust level. And I hope that the report reflects that. I think what I've been really pleased by is how the Freedom to Speak Up initiative has been really grasped across the country, not only in the provider organisations but also in the arm's length bodies as well, including our sponsoring bodies. So I'm particularly pleased that, for example, in CQC you have your own Freedom to Speak Up Guardian, because I feel that that sends the role modelling to the rest of the system, which is so excellent. It also talks about some of the work that we've been doing at national level, working with partner organisations, and when we looked at our 3-year business plan, we've actually achieved quite a lot of it already. So we realised that our ambitions were not high enough, and we're now looking to refresh that vision to be able to move things further and faster, and really looking for the sort of input from many different parts of the system so that we can feel that we're moving in the right direction at a pace that the system can deal with, but also in a way to create some challenge into the system so that things get done in a way that supports staff to be able to care for their patients in the way that they want to.
Perfect, thank you. People will want to raise a few comments and questions, I imagine, if you're happy to have a discussion. And yeah. Robert, would you like to go first?
Peter, firstly, I'd like to express my gratitude to Henrietta for the way in which she's approached her task over the last year and the tremendous progress she and her staff have made from a standing start to a situation where every trust in the country has a guardian, and many actually have more than one, and a network of them. And through the National Guardian's Office, a network of support and training and meetings takes place. And I've been to several of these meetings, and they are inspirational to see the commitment put in by people from all walks of life, if you look, within NHS trusts in relation to the freedom to speak up. It's not the end of the journey, obviously. It is a start, but the fact that this commitment is evidence throughout the country it will go in itself a long way to making staff feel safe to speak up. I have the privilege of sitting on the accountability board on behalf of the CQC, and where we meet our colleagues from the other sponsoring organisations, and I'm really happy to see the commitment that exists there as well. And Looking to the future, I think what we would all hope to see is the development of the case review process, which is currently being piloted, because I think that's the other part of the jigsaw that needs to be completed. Patience is necessary because trying to change a culture as deeply embedded as not speaking up has been in the NHS will take time, but I think we're already seeing results, and a lot of that's going to be down to Henrietta and her hard-working staff.
Good, thank you. Ted, then
so congratulations, Henrietta, and your team. I think the report shows impressive work over the first year, and my sense going around talking to hospitals and to staff in hospitals is this is already having an effect out there. Freedom to speak of guardians are often brought up as an issue. Talking to chief executives, they highlight their role. It's too. I mean, that's impressionistic. We've built, as you say in your paper, the Freedom to Speak Up Guardian into our World-led framework, and we'll be publishing our first World-led reports in not too many weeks. It's too early to say, but I would expect that the Freedom to Speak Up Guardians will feature very strongly in those reports going forward, as evidence of changing culture in the positive reports. I mean, clearly there may be reports where we anticipate that there is not sufficient focus on that, and we will be keen to point that out where we do it, where we find it. So I think it's really a very exciting first year, and we look forward to going on working with you.
Well, it's a very important initiative, so it's good to see it making such good early progress. Can I ask, what over time do you think will be the evidence that we need of impact?
I think that's a great question, and I was actually at an Institute of Business Ethics launch of Good Practice Guide to Speaking Up last week, and somebody asked the same question. And one of the panel members said, well, we're all talking about it. That's impact already. We're also publishing data on a trust-by-trust basis about how many staff are coming forward to speak up. And although that isn't the answer, it does raise some interesting questions about the numbers and whether staff are coming forward anonymously or not. And also on the themes. So up until the end of June, over 4,000 people had spoken up, and a quarter of that was about patient safety issues. But 40% was on bullying and harassment. And in fact, the Guardians have said to us, could we please change that definition to unacceptable conduct? And I think that gives us an idea of what's happening on the ground. So if we start seeing people feeling confident to come forward and talk about unacceptable conduct and patient safety issues, and then the right actions are taken as a result, it's in the feedback that the individuals give on the quality of service that they've received, in my view, is the impact. So I hope that I've made sense with that. So we say to the Guardians, when you've completed a case, go back to the individual and ask them whether they'd speak up again. 87% of the people who were asked said that they would, and 2% said that they wouldn't. Now, we're obviously delighted by the 87% because that does run counter to the previous narrative that speaking up is a career-limiting activity. But we're more interested in the 2% who said that they wouldn't, and whether people feel that they've had detriment or other negative experience. The other thing, I think, if I just turn to the report, we looked at, for example, the way that the Guardians have been appointed, and that's on page 16, and we've come up with some principles about who should be doing this role, because this is not just for the few. We want this to be really inclusive, and we've asked Trust to look at the diversity of the Guardians that they have to ensure that it's not just visible diversity, but it's all the other protected characteristics, so that any member of staff will feel supported to be able to speak up. And we've also correlated, if you look on page 17, the perceptions of Guardians with the outcomes of CQC inspections. And I think this is really important, because when we look at leadership, there's something about the outstanding trusts and what they're doing differently in terms of supporting speaking up, in terms of no barriers to speaking up in those organisations, and that speaking up is taken seriously. And you can see from the graphs on the right-hand side of page 17 that there's a really marked difference between the trusts with an outstanding CQC inspection report and those with inadequate. And so from my perspective, there's something about whether speaking up is a proxy for leadership in some way. And when I've talked to, for example, other bodies like GMC, they say that their junior doctors survey and their trainers survey almost exactly mirrors the findings that we've had as well. So I do think there's something about how information is triangulated, how this becomes part of that data set, and how we can work in partnership with other organisations so that we're looking at not just the measurables in terms of performance and targets, for example, but the softer stuff in terms of the culture and how that creates the environments where people can really flourish.
Good, thank you. Andrea.
Thank you, and thank you very much, Henrietta, for the work of you and your team and the report, which looks even more impressive in its hard copy form than the soft format. And the one thing that I did want to say was just to be clear that this is obviously focusing on what's happening in the health service and reflects the kind of limited focus of the Freedom to Speak Up review that Sir Robert took forward. It's no fault of yours, but it didn't take into consideration adult social care. And the issue for me is that very often speaking up in adult social care environments is even more difficult than it is speaking up in large organisations like NHS trusts, because if you're working in a care home, very often you will be working alongside and living alongside the people that you might actually want to be raising concerns about, and that may make it even more difficult for you to feel confident about doing that. So it's something that you and I have spoken about, but just to give you the opportunity to speak about it here. What prospect do you think there is of us looking to extend the good work that you're doing into the broader adult social care sector, and particularly to enable the principles that you've identified here about what works in terms of speaking up, and help us from an adult social care inspection and regulation point of view to encourage that in this sector?
Well, absolutely, I agree. I mean, we're talking about secondary care in England here in the report, but we've actually been doing a lot of engagement with the independent sector providers who provide care across a whole range of different settings, even including into schools, into prison health care, etc. So I'm really interested to see how they're going to pick this up, because if there's a standard NHS contract, for example, for continuing care, then that essentially means that this is part of that contract. So we are looking how we can develop training and support in a more bespoke way for different types of organisations. But interestingly, at our foundation training, which we've opened to social enterprises, hospices, etc., there's been a really interesting group of people who've been coming to that. And I think it's a real mark of the people who are running the regional networks that they're really open to people from primary care, from independent sector, from hospices and from other providers coming to their regions, because their feeling is that if their patients require hospice care, they want to make sure that once they're discharged from the provider, they're still able to be in an environment where the staff can speak up. And I think that tells you about the values. Now, what I would say is there's also something about the appetite. So this came in under the standard NHS contract. It's now obviously part of the well-led inspection framework. So there's something about the push factors and the pull factors. I mean, we welcome any provider, any type of provider to come and ask us about things. We're working with Institute of Sport, with G4S, with Spire, with Mary Stopes. So we're really open to that, and also with our pan-sector network, looking at how other sectors of the economy are addressing this, whether that's in the military. I was at Sandhurst last week. We've got the Institute of Business Ethics really interested in what we're doing. And I do think that other sectors of the economy are looking at Freedom Speak Up Guardians as that human interface rather than just a call centre, and seeing the impact that it can have. So it's very early days, but we're really open to inquiries from a wide range of different organisations.
Thank you very much.
Henrietta, can I just ask one final question? Are you getting all the support and help you need from CQC?
Well, thank you for that question. And I would say that in every different way, whenever we've approached CQC or you've approached us and we're dealing with challenging and tricky areas, and I think the case review report that's been published today is an excellent example of that, we are very, very lucky that every organisation that we work with is open to ideas, and we approach this from a very formative role, very formative perspective. So when we look to see how things can be done better, it's not about looking for finding fault, it's actually about saying, what are the opportunities? And so with working with CQC, for example, on the case review report, that's been excellent. And also in terms of the following up of those recommendations that we've made to the Trust as well, CQC will be very much integrated in that. We've had support in so many different ways. I feel that any impediment to us being able to be successful is taken away, and removed by CQC and our other sponsors. So it's, we're very grateful for that. Thank you.
No, thank you. And Ted, last word.
Just to say, you mentioned the case review report that I think is out today. You make a recommendation there for the CQC, and we will take that forward in our new guidance coming out of the consultation feedback that we're producing in a few months' time. So thank you very much for that. We'll take it on board.
No, thank you very much. And I think it's us in our role as independent. We do need to be able to look for how other organisations can support to set the culture. And so it might seem in some ways that we're looking at things in a way that hasn't been looked at before. But what I would say is that we have to do things in looking towards the future. That's what's really key in this. And we've been very, very pleased with the way that every organisation that we're working with in that respect has, responded in a way that we couldn't fault. So it's brilliant.
So, Henrietta, thank you very much for coming this morning. Looking to the future, we'll see you in a year's time. I might actually have a conversation or two with you in the intervening period. but seriously, thank you and your team. It's just a fantastic job you've been doing. So thank you, and thank you for coming. Good. Martin, can I just go back and correct myself, because I forgot to say that Paul Corrigan is also an apology for this meeting. He's been called away. He'll be back later today, but probably not before the end of the meeting. So he has apologised, and I apologise for forgetting to say that. Andrea, the Chief Executive's report.
Okay, thank you very much. So in David's absence, I'm just kind of leading off on this, but it's a team effort. So I'm expecting my colleagues to chip in. First one is the next phase for adult social care and primary medical services, and it's just to report to the board that we published the response to the second consultation on the 20th of October, and so we have moved forward with that. We're starting the work on the different way of registering services and taking that forward with our registration transformation programme. We introduced the new adult social care assessment framework on the 1st of November, and that's kind of has aligned with the healthcare framework in a much better way, has taken out duplication and simplified some of the questions, which I think hopefully will be helpful. And from a primary medical services point of view, there's a phased approach starting there, and using the new health assessment framework as well. So that's just to kind of give the board that update, although you've obviously seen the detail previously in terms of the specifics of the next phase.
Okay, good. Do you want to move on then?
I certainly will. So this is the... Oops.
I just wanted to clarify that the PMS part of it, it's mostly general medical practice. It doesn't affect dentistry and the majority of things that I do. But it's the in-hours general medical practice, which is the main focus of change.
Okay, sorry. Thanks, Steve. Right, Andrea, back to you.
So this is to move on to our first team effort, and we have Pete in the room who can answer any specific questions. In October, you approved the direction for the Digital and Intelligence work programme, and asked to have the benefits timelines and deliverability to come back to you, and that will happen in December. Just to report that the first agile project, the new way that we're doing these things, which, good for me, is sitting in the provider information collection for adult social care, has now passed the government digital services assessment for the alpha phase. And I have to say that is a very significant achievement on behalf of the team, and I'd like to thank them all very much for doing that. And it will help us to progress on with that, and we are now testing that system with real live providers, which is very useful. And we've also commenced on the discovery phase of the work in both the PMS provider information collection and in registration. And we've had some, certainly from a registration point of view, had some very good initial meetings, and particularly to connect with providers who will be using that system to make sure that we're engaging with them appropriately. And to make sure that the digital function has got the right capabilities. The first phase of the restructure has been initiated, and with thanks to the colleagues from the People Directorate who are obviously supporting Pete and his team and taking that forward. So, as I say, any difficult questions for Pete?
So, not that I think this is a difficult question, Pete, but is there anything you want to add by way of update or issues?
So I guess in addition to that, so that the Share Your Experience, which is the public-facing ability for individuals to express anything they've experienced, that's also passed the alpha. It was going into alpha when this was written. It's gone through that now as well. So that was built on the back of the provider information care at social return. So that meant we can move from one project to the next one very quickly because of the architecture that we're putting in place. So that's been very helpful. But fundamentally, we're doing three things in parallel at the moment. The first one is the clarity on the benefits and exactly why we're doing the things and what order they'd be happening in, so we all have the common understanding of that. The second one is making sure that we have the right internal staff capabilities to deliver against those over the next year, and etc. And the third one is to make sure we have the right external capabilities to augment that while we go through the process, both in terms of short-term and long-term extra work. But those are the three things that are happening. But overall, work is progressing while we do that.
Any questions for Pete? I don't think you've ever got away so lightly, Pete. This is encouraging, isn't it? This is progress in the right direction, and it's a long journey ahead of us. But this is good, and you're excited by your information pack. So
I most definitely am.
Good. Right. So let's move on then. Thanks, Pete. Let's move on to the
Mental Health
issue.
Act review. So, as the board will know, at the start of October, the government announced that an independent review of the Mental Health Act will take place throughout 2018, expecting a final report with recommendations by next autumn. We will be a part of the working group that's developing that as an expert member, and as the independent monitoring body for the Mental Health Act, we are expecting to take a major role throughout the review. We have also written to the review panel and the Secretary of State's office to confirm our plans over the next 12 months and how that we can support that, but also maintain our independent role as the monitoring body for the Mental Health Act delivery and code of practice. And as ever on the team nature, any difficult questions are for Ted.
Difficult questions, anybody?
Can I just say we're bringing forward publication of our annual Mental Health Act report, so it's available in a timely way for the review to take forward.
Good. Jane.
Thank you. And just to say that Healthwatch stands ready to help, as ever. And we decided in our last committee meeting that we're going to have a major focus on mental health. It's come out top priority for all of our local Healthwatch across the country. So we just set up an advisory group ourselves. So we are pulling together, collecting all the information we can to give you any evidence that would be of help.
Lewis.
Well, one of the slight disadvantages of having a public board and a private board is that because of the report that we've got coming out, we've obviously talked a little bit about the Mental Health Act reform process as well already. But so board members wouldn't mind. It'd be just important that we don't, at the public board, give the impression that we haven't had a detailed discussion about this issue. And there's a couple of points that came out of our early discussion that I just want to mention. First of all, I'm on the advisory panel, not representing CQC, but independently. And the first meeting was yesterday, and a couple of important things came out of that, I think. One is quite a long list of potential reforms. And another is a very strong feeling that the ethnic differences in the use of the Mental Health Act have to be addressed, along with a recognition that that isn't just an issue of the Mental Health Act, but an issue of how mental health services themselves work, and also some of the disadvantages, economic disadvantage and racism in society that then eventually feed into Mental Health Act detention rates. Just so that you know, the use of the Mental Health Act is 4 times higher in BME communities than it is in white British people. The use of community treatment orders is 9 times higher. So these are very big differences. And the Mental Health Act is probably the recipient of a long process of disadvantage in which some ethnic communities experience. And I think our role will be to, in CQC, will be to make sure that we have a proper discussion of the data and a proper focus on those kind of priorities, even though there is a long list and quite a lot of expectation that, of what the reform process may cover.
Okay, and so just to be clear, I mean, at appropriate times, the CQC people led by Paul Elliott who are doing this will be at the board, talking from a CQC perspective. I think some of what you were saying was from helpfully about what you think the CQC role will be. Some of it was more from your personal involvement. But the CQC team will be here when we're here to report, I think. Yeah, Ted's nodding. Good, thank you, Lewis. Anything else on the... I mean, it's not doing it justice to say anything else on the Mental Health Act review because there's a huge amount, as Lewis has already said. But for this morning, is there anything else anybody wants to raise? Okay, so let's move on then, Andrea, to health and safety.
We just wanted to report on the Health and Safety and Wellbeing Committee, which was held in October, and just to highlight for the board the information that was provided, which is also in our performance report later, around accidents which had happened with our staff, including threats to staff and violence, and that is leading into a very important piece of work around the risk assessments that we're doing with staff to make sure that we are looking at what risks inspections or any other activities pose, and ensuring that they're supported by the health and safety team in mitigating those risks. The committee looked at a revised health and safety policy, which has also been through the executive team and has now been approved with a few amendments in the private session of the board, so that we can now roll that out. And we're supporting all of that work with some very specific codes of practice to enable particular types of activities to be addressed. And they're highlighted here: the Driving for Work Code, the Risk Assessment Code, as I've mentioned, and the Health and Safety for Home Workers. So there's an awful lot of activity going on there. It's really important for us, protecting and supporting the health and well-being of our staff, that we really focus on this, and it's important for the board to see it. But it sits within the Customer and Corporate Services, and Kate will answer any questions if people have them.
So this is really important, and it's important that there are sort of 3 levels of review of this. There's us as a board with the oversight, there's a sort of management executive responsibility, and then there's a responsibility for our staff themselves, because we need the right policies and we need the right follow-ups, but people have got to also take responsibility for their own health and safety within that. So, Kate, I was just a bit concerned, but maybe I'm not reading this fully, that there appear to be some quite important pieces of mandatory training where the take-up rate is less than 100%, and we need to get to 100%. It's a journey, I know, but how worried should I be by what I've just read?
Okay, thanks, Peter. I think that there's 2 areas. There's the driving safety at work and there's the workstation safety. Whilst you shouldn't use the term in the health and safety arena, we do use a carrot and stick for both. So the carrot for both is to improve comms, to engage people, and just the attendance at the health and safety meeting, the attendance from the directors has vastly improved since we've had the new health and safety team in place. So the carrot is working well on both. The stick for the driving safely at work is that through finance we have actually said that anybody claiming mileage cannot do so without having undertaken the driving safely at work mandatory training. So the 23% of people who haven't completed it probably haven't driven for work yet this year. So I think that's the way to do that. The stick for the workstation safety, which has to be completed every 2 years, relies on good information coming out of the system. The system that we've got at the moment for that isn't particularly versatile. It's being replaced. The new system will be in place hopefully by February. So then we will be able to highlight individuals who haven't undertaken the training, and then we can ensure that they are chased and that they complete it.
So, I mean, I know from previous experience it's really difficult to get up-to-the-minute data because you have people joining who won't have done a course yet but will do so when they're supposed to. But if we can find a way of satisfying ourselves that in a reasonable time frame everybody who should be doing mandatory training is doing it, I personally would feel very much happier. But it's a challenge, I know. Robert, did you want to raise something?
Yes. I see that we our policy and so on goes through the Health, Safety and Wellbeing Committee. What I'd like to know is what steps we take to find out from our staff more directly what they think we need to do for them in order to help them exercise their responsibility to be safe, first point. And the second point is that, as I understand it, although perhaps we need to make it clearer than we currently do, when we talk about staff, we also talk about those who aren't actually formally employed by us but work for us, like experts by experience, outside advisors, contractors, and so on. And what steps we take to assure ourselves that they are kept safe as well, and in all the different ways they need to be kept safe.
Okay. So on the first point, what do we do for our staff? And I think particularly adult social care have been very engaged in working groups to actually look at risk assessments, to consider all the different risks that are in play when they're out inspecting, and that's now being rolled out to PMS and hospitals. As I say, we've got the new health and safety team. So we are really engaging people in understanding what their risks are and how we address them, and all of the policies, working practices, etc., being pulled together in a how do you keep yourself safe at work package of documents. On the second point, in terms of the SOADs, experts by experience, SPAs, I mean, in formal terms, all of those people have a responsibility to abide by our policies, but at the same time we work through the Flexible Working Office and the experts by experience contractors to actually make sure that people understand what they need to do. But I do think that there is scope to increase that awareness, particularly when we're introducing new policies, and we've got new engagement ways going forward.
And if I could add, on the engagement directly with staff, as Kate says, Sue Howard, who leads on these issues for me in adult social care, has done a tremendous amount of work with individuals. And one of the things that we're looking at is making sure that when we're doing the inspection planning, a key part of that inspection planning is to consider the risks that might present themselves, and then to ensure that staff are able and supported to have conversations with their managers about what they need to do to mitigate that risk. And therefore, if there are things that are not immediately available, we can escalate on that basis to make sure that people are supported. And the other thing to say is that the Health and Safety and Wellbeing Committee has staff representatives on it, and these are conversations that also happen with the joint staff groups from the trades union point of view, as well as the staff forum. So there's a variety of different mechanisms that we would be doing that in.
Okay, anything else anybody wants to raise? Good, thanks Kate, that's very helpful. Andrea, back to you.
Moving on to the Information Security Internal Update Report, and board members will recall that we had an independent external review of the incident where we lost DBS certificates, and that review made a number of recommendations, and so we are publishing today a report which sets out a review of how well we've done with those recommendations. And the review notes that there's been a very significant programme of work to make progress in implementing those recommendations from the 2016 external review. The review has concluded that 4 of the recommendations have been fully met and require no further work. One recommendation on information risk management in projects was fully met, but we've changed working arrangements since then, so we'll need to do some more work to make sure that those changes are appropriate for the new way of working. The final recommendation was about cultural change, which, as I'm sure you can imagine, is a much more challenging thing to do, and that was recognised. The review recognises that progress has been made, but there is more work to be done. And so the review makes 4 new recommendations. 2 relate to the ongoing work on the culture change. 1 relates to the change arrangements for the project management, and 1 relates to overall programme governance, to make sure that we're pulling all of this together. So those are now part of CQC's Information Governance and Security Improvement and Change Plan, and work is underway to progress those recommendations, and we're proposing, and had a brief conversation with Paul as chair, that the board's Accountability and Corporate Governance Committee will continue to oversee the progress in that work. But the recommendation around culture change does actually reflect what does the board do around this, and so what we plan on is to bring a paper back to the board once those discussions have taken place, to discuss with you how we take that forward. So not really to get into the debate today, but to say we'll bring that back.
Okay, I mean, I think reading the report, it was very complimentary about the way that you, Andrea, and the executive team had dealt with the issue. So, I mean, it was more than a sort of neutral, factual report. It was quite glowing in its compliment for the progress that's been made. I think it's worth just noting. Anybody want to raise anything in that regard?
And I think on that basis we should say thank you to Malta as SRO and others that have been working with him to achieve that, because I think there has been an awful lot going on behind the scenes which people won't have seen.
That was meant to be a thank you from me, but anyway.
I just thought I'd reinforce it.
Thank you, Malta. Right, Andrew.
Sleep-ins. So we've set out here just really to report to the board that on the 1st of November the government made an announcement that it was ending its 3-month suspension of the HMRC enforcement actions relating to the minimum wage for sleep-in provision. And there is now a new scheme run by the HMRC, the Social Care Compliance Scheme, and organisations have 12 months in which to conduct a self-review of their liability for sleep-ins. Work does continue to explore the case for government financial support for affected providers, and that is continuing, and conversations are happening and was set out in the government announcement. And just to reassure the board that this is something that our market oversight team is keeping a close eye on. Of course, because the market oversight scheme only looks at the larger, more difficult to replace providers, we're not looking at the whole picture, but it does give us some insight into what the issues are, and we continue to work with providers, continue to work with across government to monitor the impact of this and to see what's going to happen, and clearly if there are issues that come out of that, we'll bring those back to the board.
I think it's worth adding, Andrew, isn't it, that there is still a huge amount of concern from providers of all sizes about the impact of this, which we will monitor, as you say, but it doesn't take away the concern.
I think there are concerns on all sides. There's concerns from members of staff who obviously have been working and have not necessarily been paid at the level that they were expected to. There's concerns for providers who felt that they were following guidance which had originally been written a particular way and then changed, and that causes them a particular concern because their contracts did not include payment at that higher level, and it then brings a concern to commissioners, and quite a lot of the impact of this is in the learning disability service arena, which is predominantly publicly funded, and therefore the impact on commissioners is significant as well. So I think that whole aspect there is very difficult, and I think we do need to keep a close eye on it.
Lewis.
Could you just give us an idea of the magnitude of the effect here? I mean, I recognise people are concerned about it, but say to a local authority or to another commissioner, or for that matter to an individual provider, how they're concerned, but how big is the problem, financially speaking?
So there are various estimates that are around. The voluntary organisations, Disability Group and Care England and various other groups did some work and came out, I think, with the figure of about 400 million was a potential past liability. But this is part of the work that the government is doing in terms of really understanding what that is, both in terms of the backlog that there might be, but also in terms of the ongoing impact. And that's been part of the discussion that they're having around what support needs to be had. So, but clearly, if that came in as a bill, that would be very significant in a sector which is already financially quite stressed.
So I think, Lewis, first of all, there isn't a lot of accurate data at the moment because there's some lack of clarity even now about exactly what this will mean. But to take Andrew's point, there are sort of two dimensions to this. There is the impact on the past, and certainly some of the big providers have been very public in saying, at best it wipes out our years and years of accumulated reserves, but it doesn't bankrupt us. But I mean that does huge damage. But then going forward, this increases the cost quite significantly. And that's fine if the commissioning takes into account that increased cost. But we know the commissioners are under pressure, so there's certainly at the moment, I think, some uncertainty about how that plays out.
Okay, that's helpful. I mean, I suppose it's getting the information to sort of fill in the gaps in that, so that would be really helpful. I don't know how the 400 million, was it, translates into cost to a local authority, for example. Or, so it would be helpful to understand this, because I wouldn't like our discussion to stop with provider concern. I suppose that's what I'm saying. I think there is a sort of bottom line to this which we need to understand.
But the critical point from our point of view is twofold. One, the impact on those providers who sit within the market oversight scheme and our assessment of their financial sustainability, which is not the whole, all of the providers that might be affected by this. The second is, and that's across the sector, is what potentially is the impact on both quality of care but also the models of provision. Because if there is a restriction on finances being available, then will we see people move to the sorts of services that that might be economically more advantageous but actually are not consistent with the good practice that we know is important in terms of the models of care for people with learning disabilities. So I think we have to be very, very vigilant about the potential impact on the quality and the model of care. Okay.
Right, so we then move on, I think, to CAMS, is that right?
Yes, so we report to the board regularly on the publications that have come out since our last meeting, and the very significant one that to highlight here is the first phase of the Children's and Young People's Mental Health Services Review. And I don't know how many of you have read it in detail, but I thought it was an absolutely excellent report, and really highlighted some very significant problems which other commentators have picked up as well, but will feed into to the ongoing work that we're doing. And again, colleagues from across hospitals, PMS, integrated care and policy and strategy can answer any specific comments on that, but just to commend people to read it.
Anybody want to add anything, Ted?
I think it's a very important report, and the final report I think will be very important because it'll be moving towards what can we do about this. I mean, this is a very long-standing problem. It has been a problem for many years. It's exacerbated by the increase in demand, and it sits between the providers who we regulate and the commissioners who we don't. And I think that is in so many of these things, it's a system issue as much as an individual provider issue. And I think that's the important thing we're going to bring out here.
Sorry, Lewis.
Just very briefly, I think it was a very good report, actually. There's a kind of momentum building about this issue, and our report is part of it. I think Ted is right to ask what is then going to happen. In fact, of course, the children's mental health is quite a broad area, and in fact, we are only concerned with some of the providers. We're concerned with primarily the health providers, but of course the issues run across a number of agencies, and in the end that will be one of the tasks to translate what we find into something which reflects the broad nature of the problem. But it's a very important report and something we mustn't let drop. We do produce quite a lot of reports, and they're often, I think, very good, but it's not absolutely clear what their impact is on the system, and this is one that we must make sure has a proper impact.
Robert. Sorry. You put your hand up, Robert, so I thought it was you.
That was me.
It was her. Oh, beg your pardon.
Sorry, can't you tell?
No, I can't.
Young people tell us that they don't want to get ill in the first place. They don't want to have mental illness in the first place. And I just wondered what space we are capable of having to discuss prevention and advice and helping young children so that they don't get ill in the first place.
I very much hope that will be covered to some extent in the second report, but as Lewis says, it is a big issue that goes way beyond these individual providers into wider society.
Apologies, Robert. So, and then lastly, just to note Eileen's, the replacement for Eileen, the process is underway.
And there's nothing more to say about that until David comes back from his holiday.
Right, okay, perfect. Is there anything anybody wanted to raise on the Chief Executive's report before we come on to the performance report? Okay, so that does take us then on to the performance report. Malta, are you kicking off on this?
Thank you, Peter. So you have in front of you the performance report for the last 2 quarters, the first 6 months of 2017-18. I'll just do a short summary and then invite my Chief Inspector colleagues to say a few words about each of their areas. Over the last 6 months, we've undertaken 9,000 inspections. On 7,000 or so of those, we have published our reports. The other reports are yet to come. Within that, we've issued about 1,100 enforcement actions. An increasing number of those are criminal and civil actions as well, particularly in this quarter. I'd also like to highlight the improvements that you see in the performance report, particularly in the areas of registration, how we respond when concerns are raised with CQC, particularly the work through our National Customer Service Centre, where over the last few months the performance has really improved back to where we wanted it to be. And we have to say thank you to the Customer Service Centre team in particular. Also to highlight in this quarterly performance report, we've included the annual awareness survey of the public of CQC, which shows positive results in terms of the general stakeholder awareness of CQC and the public, and a rising trend from past years, which is as we'd wanted to be. We also see within that those groups that are more likely to be thinking about and choosing their care are more likely to make use of CQC resources and be aware of it. So, for example, the awareness of members of the public of inspection reports is much higher in the age group of those between 55 and 64, for example, which we obviously don't have clear evidence for that's related to the fact that age group is more likely to think about care either for themselves or members of their family. Coming to the areas where we think more work is to be done, we're broadly on plan in terms of our inspection schedule and where we'd want to be, but we're realizing that there are some areas where the complexity of the work that we're taking, such as enforcement, means that that can become more difficult to meet, and is also visible in some of the productivity figures that you see in the performance report as a result. Stepping back from the operational activity and looking at our commitments against our business plan, 3/4 of our business plan milestones are rated on progress, green, which is very positive. About 1/4 of them are in a space where we probably would like to have somewhat more pace on the delivery, but none of them are rated with a significant risk of non-delivery, i.e. rated red. Where they are reported to have an impact on delivery where we'd want to be, it is often because of the complexity of the work that we're undertaking, such as some of the digital changes that the board has discussed a few times in the past. And then finally, looking at our budget, we continue to underspend this year against our budget. At the moment, our underspend forecast stands at 7.8 million. Though some of the challenges that we're facing, particularly with recruitment over the rest of the year, might mean that the underspend increases further for the rest of the year. That's all I wanted to say in terms of the summary. Andrea, do you want to start with a few words on?
Thank you. Thank you very much, Malta, and to your team as well for the presentation of the report, which gets ever more interesting. On the registration side of things, as the board knows, I have the overarching responsibility for registration for all 3 sectors. And just to pick up a couple of points on there. The first is we've given you, I think for the first time at the board, the information on the unregistered providers. This is a significant element of our work in registration, where people refer to us services that may be operating without having registered with us to deliver a regulated activity. And that is obviously not what we want to have happen. And the kind of consequence of that is sometimes people didn't realise and they need to be reminded, and we go through the process with them and they do get registered. In other circumstances they stop providing the service, and in other circumstances we have to take enforcement action to make that happen. So it is a significant element of work, and we've not reported on it previously. And the level of activity that we're seeing at the moment, the forecast for the full year would represent a 20% increase in activity compared to last year. So again, it's a significant chunk of work, and obviously takes up quite a lot of time on behalf of the people who are having to deal with that. The second thing I just wanted to say was that coming off the back of the improvement from the customer call centre around processing the applications for registrations, which has improved over the year following the reorganisation of the team earlier in the year. We are seeing a relatively stable performance. If you kind of took the little pink line on slide 10, which is this year's activity, it would probably be coming out roughly at about 84% across the board, which is an improvement on last year. Doesn't take us quite to where we want to be, which is to get us up to making sure that we're making decisions 90% of the time within 50 working days. Some of the aspects that's been impacting on us, we have, it is an improvement in performance. It's still not where we want to be, but we have had a significant level of sickness within the team, and some very complex registration decisions that we've had to make there. So that has impacted on that. But we are, through the registration transformation programme and also the continuous improvement work that Joyce Frederick and her team are leading on with others, we are hoping to see that performance improve as we go forward. I did want to mention the point about you may have picked up on page 4 of the report at 4D, that we were looking at those services which were in breach for more than 4 quarters, and we've identified that in the vast majority of places we've got either enforcement action is going on, or we've got an inspection underway, or it's planned. There were 8% that on the figures that you saw didn't have an action identified, and we have reviewed all of those. There are a variety of different reasons for that. Some of it is data recording, some of it is we do know that there is action going on, and but it's kind of not manifesting itself in CRM, so it's not pulling through into the report. But heads of inspection have looked at everything to make sure that we're not losing what we need to be doing there, which is important. I just wanted to pick up on the Malta said that we were pretty much on target with the inspections that we were planning. Adult social care is probably the area where we're least confident of hitting those targets through to the end of the year. We're a little bit off the pace at the moment. We have been looking at that in terms of how we can recover that position with use of bank staff and other ways of managing the activity. But we have had some turnover. We have had sickness in those services as well. And what that creates for us, unfortunately, is we never reduce the number of locations that we've got to monitor, so the monitoring of the notifications, the inquiries, the safeguarding, the whistleblowing that comes in then has to get spread amongst a smaller number of people, so that increases the time that people individually spend on that, which obviously decreases the amount of time that they can spend on inspections. So we are rescheduling inspections to make sure that we're managing risk. Going back to inadequates and requires improvement, but that is causing a bit of a drift on some of those services that we previously rated as good. And as I say, we're working very hard to try and address that, but it is a difficult situation for us to manage at the moment. And last but not least, we are continuing to improve the performance on report writing. And whilst there was a little dip in September, which I think is a consequence of the holiday season in August and September, because those people who don't have kids of school age go away in September, and those who have kids of school age go away in August, and that means that time is taken out in the short period of time that people have got to turn reports around. That dropped us by a percentage point in September, but we hope to improve that as we continue through the year.
So there's a huge amount of very positive news in this, and I think particular congratulations to the registration team. A lot of really good stuff being done, but there's also a way to go, isn't there? We mustn't lose sight of either of those things. A lot of progress, but we're not quite there. Are there specific points anybody would like to raise?
Stephen.
Pardon? You want me to go to Steve and Ted first? Okay. Right. So I've just had my strings pulled by the acting chief executive. That's fine. So Steve. Ted.
I'm delighted to talk. Didn't get a chance. That's good. So this is obviously a big year for us as we've completed the first GP programme earlier in the year. But we've also been spending a lot of time on health and well-being of staff. And I'd like to commend Sam Banga for his work, because that if you can keep the staff healthy and motivated, then productivity is good and quality is good. And so our sickness rates are low. We are now on full recruitment, and we're reaping the benefits of that extra attention and support. Our performance dipped a little bit when we spent a few weeks focusing on the next phase of GP rollout, which will gradually come in from this month onwards over the next year or so. But actually productivity is good, and the quality of reports has improved, and the timeliness of publication of reports has improved dramatically over the last 6 or 7 months. The detail in the report, like Andrea, we continue to focus on what is reported in the report is a breach of 4 quarters for those that have been inspected. In fact, the numbers have gone down. We have a narrative on every single one of the cases. The numbers are small. In the report, it also talks about our work on defence medical services, which we're very pleased with. That is funded by the defence services, not by the NHS or by the providers other than defence services, and the feedback has been very good. We're just waiting for a decision on ongoing funding linked to the defence spending review and change in personnel in the defence services to see whether we carry on with that in the future. The rest of the detail is in the report. I don't want to labour it.
Ted.
Sorry. Thank you. As the board knows, we launched our next phase of hospital inspections in August. And so we're now 3 months into that, and I think it has been going well so far. We haven't produced the first reports under the next phase, and I think that is the next milestone, and we expect that to occur in the next few weeks, probably early December. So we've been making good progress on that. What we have done over the last few months is introduce a detailed dashboard for all our frontline inspectors so they can monitor their own performance, and that feeds up to the Directorate dashboard, so we review that on a regular basis. And we are making forward progress in lots of performance areas, but there is more to do. 2 areas I'd like to highlight, because they come out in the report, is productivity. Now, because next phase was delayed because of election purdah, we're a bit behind where we wanted to be when we originally planned this financial year. But having said that, we are launching 15 NHS Trust next phase inspections a month, which is exactly the number we anticipated in this part of the year. So we believe we're on track. When we get up to full speed, it'll be about 20 a month. We have always planned to do that during next calendar year, so we'll be starting that early after the new year. And I think if we can achieve that, I think that'll be a considerable achievement, because it enables us to get towards the annual cycle of NHS Trust inspections, which we're aiming to achieve, which was a bold ambition, and as yet we're still on track to achieve that. The graphs you see here reflect, if you like, the previous activity, although I think there is some issue about the way that the inspection activity is captured, so it may not all be reflected in these graphs. But having said that, they reflect our plans before that, the graphs on page 13. The area of concern remains around report timeliness, as you'll see in the graphs on page 21. That hasn't fed through into the September KPIs yet. Having said that, we are making progress. We're still publishing a few reports from the old comprehensive NHS inspections, though those are the reports that cause us most difficulty. And I have to say they have been delayed, and the graph reflects that. But we were having very few of those left to publish. We are continuing to publish independent health reports under the first phase. We've made great progress in terms of reducing the delays in publishing those. We've halved the median time of publication since March. We're now down to, if you look at the October figure, the median time to publication was 48 days, which is a substantial achievement for the Directorate over the last few months. As we go into next phase, as I said, we are planning to publish next phase reports over the next few weeks. We are managing that very closely, and as yet we are on target to publish those within our KPI. And remember, we have changed the report format, we've changed the whole process of quality assurance, and that was to tackle this issue of delays in report publications. So at the moment, we're on track to deliver the next phase reports in a timely way. We haven't yet done so, and we're monitoring that very carefully, but we're very closely focused on it going forward.
Robert.
Thank you. Just picking up what Steve says about the staff and the encouragement about the level of staff sickness. Could someone help me as to what we benchmark that against? I mean, I don't know whether just under 4% is good, bad, or indifferent compared with other organisations. And the other slight curiosity, and I don't know if it is one, is that the line is almost flat. In other words, there's no change in the sickness absence rates over the year. And as a layman, I would have thought you'd have more sickness during the winter months, but maybe all our staff are so young that doesn't happen. But
Kate?
Yeah, I think that we set the 5% target based on other similar businesses. I think if you look into the health service in certain areas, it would be maybe up to 8% would be normal. If you're looking into commercial businesses, it's much lower. So it's with similar organisations, and yes, it does increase during the winter months. Not much. Yeah.
And one other thing to say is that there is variation amongst the directorates, and across the 5 directorates, and probably the adult social care and registration directorates. We've got a higher level of sickness, which is partly reflected because our age profile is different, and we have an older cohort of staff, and we have more long-term sickness. I mean, for absolutely legitimate reasons, people have cancer, and they've got to go away and have their treatment, and we expect them to come back, and all of those good things, but that will obviously have an impact. So there are variations, but the important thing is monitoring it, making sure that we're supporting staff when that's appropriate to do so, and particularly taking into consideration what we're doing to support people who may have mental health problems. And we've done an awful lot of work over the last year around mental health awareness training for managers to enable them to support their staff in the most appropriate way. And this has been a great initiative from the Academy, but also with staff from TED's Directorate in mental health, who have been leading on that training with staff, which has been incredibly well received. And we are now looking to roll out some of the materials that we've used for managers for all staff as well.
Steve?
Thanks. Just to add, I mean, we do all take this very, very seriously. Most of our workers are home workers, and we all feel that there's an under-reporting of sickness by home workers, and probably they've got really committed staff who work very hard, and we're very conscious of the isolation that they might feel and can easily get into. And so certainly since Ruth, our Director of HR, has been here, who is a really excellent appointment, we've been thinking about how we can encourage people to link up, work together more, even though they work as home workers, encouraging more meetings, telephone calls between them to avoid isolation, which will help both keep them going physically in the job, but psychologically as well. So we do take it very, very seriously.
Could I just ask a follow-up, which is the Nhs Staff Survey includes a question which tells us the, in my view, appalling percentage of the NHS staff who say they go to work even though they don't feel fit to do so. Now, I mean, one can argue about the validity of the figure, but that's what the figure is. Do we have any similar measure in the which I appreciate is a little more difficult when people are working at home, but I just wonder whether I mean, we value our staff, and no doubt we value particularly their commitment to the job, but I would not like it to go under the radar if there was a figure like the NHS has in our staff, which I very much hope there isn't.
I don't think the staff survey includes that specific figure. When we do ask a question about morale, but we don't ask that specific question. When we bring the staff survey back to the board in the new year, because we've just completed the staff survey and we're just kind of starting to get the results now to the executive team, maybe that's something that we can consider in terms of what we might want to do for the future.
Jura and then Lewis.
Just looking at the registration process, we implemented a new system on page 10. We implemented a new system for the NCS, but I'm not seeing, unless I'm reading it incorrectly, an improvement on the registration process, and we still seem to be way behind the KPIs. Maybe reading it incorrectly, but I just wondered if we're seeing the benefits of this new system or not.
Where did you see the bit that's...
I was looking on page 10, where it shows you the registrations, application processing, but the trend is still pretty flat. We had it up in August and then flat in September. So I'm just wondering if this new system is aiding the folks there.
Okay, just is it chart B on page 10? Is that right? Yeah. Okay, so basically it is an improvement on last year because we've got the green line is the 2016 figure. So we set a stretch target of 90%, so it has actually improved on last year. And we will keep that under review as to whether or not it's the correct target. In terms of NCSC processing, which is actually the easy part of the registration processing, they are actually doing the turnaround of the registration applications within their 5 days, and they are achieving that at 100%. The chart that we've got here is about whether or not the whole process is completed within 50 days, and there can be some quite difficult and protracted registrations once that early bit has been done. So NCSC are getting the benefits out. Whether or not that target is realistic, given some of the complicated registrations we get in, remains to be seen, but it is that performance has improved.
I think my question was more around the benefits of the system.
Yeah.
Has it reduced time? Has it improved the quality that we must have we implemented a system with certain benefits. Have we realised the benefits are helpful?
So we're in the process of developing that, Joro. It's not that we've kind of implemented that completely. We've started to do the discovery phase on the new digital system for registration, and that will lead us into a new way of doing that next year. But we wouldn't be expecting this is the benefits that we're seeing here are benefits from improved organisation of our teams, because we separated them into healthcare teams and adult social care teams, so that people are focusing on the specific registration areas that they are familiar with, and that speeds up productivity. It's focused on some of the improvements that we've made in aspects of the registration process, both with the work from NCSE in passing through applications to the team, but also NCSE kindly taking on some of the lower risk pieces of work, which has meant that we've freed up the time for registration inspectors to concentrate on those other areas. And then there's also the whole issue around kind of the capacity of the team to deliver, given the issues that I've mentioned earlier about sickness and the long-term sickness absence, but also turnover and the demand of unregistered providers. So it's a complicated picture, I think it's fair to say.
Okay. Lewis.
Can I ask two things? Both relate to items which aren't usually in the performance report, so they stand out for that reason. The first is the issue of the unregistered providers that you referred to, Andrea. I was trying to understand how this comes about, because there are over 100 a month coming to our attention. And your prediction for the year, therefore, is just under 1,500 for the year. So these are unregistered providers, and we refer to them in the performance report on slide 10 as being, you refer to them as volume of enquiries, which I suppose raises the question about how we then know about them. But more broadly, I suppose my fear would be that these are providers, I may be wrong about this, but my prejudices tell me that they might be providing a model of care that we might not have registered. And so I'm wondering whether we have any further information about the breakdown of who they are. Are they, for example, residential settings for people with, for older people or people with learning disability? Are they being established with the agreement, in some sense, of local commissioners, local authorities and CCGs who might be paying for people to go there? And also, how quickly are we discovering, given that they are unregistered, how do we know about them and how quickly? It seemed to me that this is slightly strange phenomenon. Perhaps I'll pause there and then come back to my second point later. It's completely different.
So it may well be a good idea for us at a future stage to give you a little bit more information about what's behind all of this, because this is across all three sectors, and there's actually quite a lot in the sector that Steve is responsible for, where we see unregistered providers, people setting themselves up to provide certain procedures and those not being registered with us. How we get to know about them is that people tell us about them. So they will, and sometimes that is local commissioners who pick up the fact that there are services that are being provided locally that they do their due diligence on and discover that they're not registered with us, and so they raise it with us. Very often it's members of the public, or it may be other healthcare professionals and social care professionals who are raising it with us. For example, we've had services where people have been looking after people in their own homes, and actually, is that a care home? What is the nature? Is there a regulated activity that's being provided? And sometimes these inquiries come to nothing because there isn't a regulated activity that's being delivered, and we can close it on that basis. Sometimes it is that people were trying to do something below the radar and we have to do something about it. Sometimes it's that actually they weren't as familiar with the regulations as they should have been, and we've had to kind of take them on an education journey to make sure that it's been established appropriately. So that kind of gives you a bit of a flavour, but what we can do perhaps for the next quarter when we're doing this report, and I'm looking at Malta who is kindly nodding at me, to include a little bit more in terms of what the breakdown is, and we've got a helpful blank quadrant on that page, and so I think that what we'll do is to provide maybe a pie chart of the different services that relates to.
Okay, second question.
Second question relates to the public attitude survey, which I think it's done annually, so we haven't seen this for quite a while. So the sort of key slide, I think, is number 18, page 18. Just as an aside, just as a sort of irritating statistical aside, it doesn't seem to me that the numbers are the same and different. Now, there may be a reason for this, I may be misreading it. But it looks like the overall awareness of CQC is 71% once prompted. But on the graph it's given as 60, I think that's 65, is it? So just there's some discrepancy in the figures, I think, unless they're reporting different things. But anyway, putting that aside, it is actually quite interesting reading, and one of the things that comes across is, first of all, that awareness is rising. That is largely prompted awareness. I assume that means people are given the name of CQC and we say, well, do you know what they do, or something like that. The unprompted awareness is still quite low, but also rising. The figures for different population subgroups are fairly similar, except when you come to people who are choosing care homes, when they're much higher, or not much higher, but they're significantly higher. And also when you look at how many people know about our reports or have actually read a report, the people who are interested in care homes, that figure is now much higher. And it just tells us, I suppose on the positive side, how important our work is to people who are trying to choose care homes for a relative. I suppose on the more negative side, how maybe there's a little bit of catching up to be done in other parts of other sectors to give the same relevance to the public that our work in care homes and social carers has already achieved. So I think all that's pretty positive. I do have a question at the end of this, which is whether we know how this compares to other national regulators. So do we know, for example, what the equivalent figures, or can we know what the equivalent figures might be for Ofsted, or, I don't know, Ofcom or Ofgen, well, Ofgen, I suppose, where there's a broad public interest in what they might do. So, the figures on the face of it seem good when people are directly asked about us, not so good when they're just spontaneously asked who is doing this kind of work. But is that what we might expect from a survey of a national body like this?
So that was an unprompted question. If you put a prompted question, we'd have had the answer for you in full. But Malta may have a bit more to add.
So thanks, Lewis. So just on the statistical question, Graph A shows you the general awareness that there is a national regulator in health or social care. Graph B shows you the awareness that there is a Care Quality Commission. And as you'd expect, less people are aware of what we're called than are aware that there is a regulator. That's where the discrepancy is.
So it's a different question.
Yes, that's where it comes from. So just to clear that up.
We're putting that on the
on your point around the awareness of reports, you're quite right, and our hypothesis is that where people have a choice of service or more deliberating about where they receive care, they're more likely to be aware and look at it. That's also coming out in the age groups. And as you said, people who are choosing a care home. Interestingly, it doesn't come out everywhere. So maternity is an example where you'd think there is more deliberation and choice, and you don't have the same effect as on care homes. But I think it is important input and evidence for the work that we're now doing on understanding how we actually share information with the public in particular, and how we're reviewing how we publish inspection reports and bring those information out, not just through the reports, but generally our website. As well, and hopefully that'll help us with that wider awareness. On your question how comparable it is, I'd suggest we bring something back so you've got the immediate facts in front of you. But from what I'm seeing previously, this is a good and comparable result rather than being far behind other regulators. But I'd rather look at the numbers again and then bring them back rather than try and remember them now.
Yeah. Any Paul?
Thank you, Peter. This is I think, probably for Malta and Kate together, because I was just interested in the underspend on pay, basically, and the comment that Malta made about recruitment. Because as I recall, a couple of years back, we were struggling to recruit inspectors as fast as we needed to in order to complete our inspection programmes up to the timetable that we had set ourselves, and which we had communicated to the public and to DH. And I wonder whether we are getting ourselves back into that sort of problem, or whether it's the underspend is related to other recruitment problems.
Okay, so the underspend is related to the fact that we haven't been able to recruit in certain areas, and in some cases also on the pay underspend, it's related to SPA usage as well, that we haven't been undertaking the same number of inspections as we originally thought we would when we set the budget and profiled it. So we are expecting, we look at who's in the pipeline coming through, who's been recruited and about to start, and we feed that into the forecast. So the forecast is actually as accurate as we can be in terms of what we're doing in terms of recruitment activity. We've also had discussions separately about where we need to recruit to, and Ruth has got a very clear target, and she's also done a very good plan of what she can realistically undertake and who she can get through the door, and we're proactively recruiting people rather than waiting for vacancies to occur. So I don't think we're going to get back into that situation, but we are still going to underspend this year.
It's also worth saying that where traditional recruitment is difficult, we are considering alternatives on how we can deal with that. So a particular case in hand is for my team of analysts, where we want to automate quite a lot of the current processes, and actually we can do that by investing in work that we do over the next 3, 4, 5 months, rather than recruit additional people into our team and to deal with it that way. So just because we can't recruit doesn't mean that we can't do something about some of the areas where we need the man-woman power to deal with a particular issue over the short term.
So if we look at the chief inspectors, in terms of the targets that we've got for inspections over the current year, are we going to hit those targets, or are we going to miss them? And if we're going to miss them, are we going to miss them because we haven't been recruiting, or is it because of some other factor?
Well, at the moment we're predicting we're going to hit our targets within hospitals. recruitment is much, much better than it was, and we are close to where we want to be. I think our main concern is the turnover, and you'll see it's a turnover of 11% or so. And that as Kate mentioned, we've got to be proactive about recruiting, not waiting for a vacancy and then filling it and having a gap, but actually having a constant stream of people coming in, because I think with a 10% turnover we can predict that. I mean, the real problem is that we're geographically dispersed, and so we've got to have the right people to recruit in the right areas, so it isn't as easy as it might sound. But having said that, I think we need to be more proactive in that. Going into the next financial year, some of the risks that we know we face in some of the sectors, independent health, for instance, where we've identified new risks, we need to just review the number of inspectors we need to do that, and we are doing that going forward. But I think, as Kate mentioned, Ruth is taking forward a recruitment strategy, and I'm pretty confident we'll have sufficient new recruits to actually deliver what we need to deliver next year as well.
Could I just add that I think that a turnover rate of around about 10% is what you would expect. Doesn't feel high to me at all. So I think, as you say, it's where we are. I didn't want anybody to think that was a problem.
No, it's actually having a dynamic interchange with providers on our staff is actually very positive. It just creates an operational issue.
Exactly that. Andrew, do you want to?
So to answer the question from an adult social care point of view, as we set out in the report at 5B, we don't think that we will hit all of our targets in terms of going back to services at the point that we said that we would. We will absolutely make sure that we are picking up inadequates, that we're picking up requires improvement, and that we are responding to risk. But in kind of prioritising our work in that way, and also recognising that there are significant risks which are being reported through to us that are coming from members of the public, that are coming from members of staff that we need to respond to. That is shifting the inspection profile in terms of the inspections that we need to do. So I'm worried about that. Clearly, our vacancy levels have had some impact on that. The levels of sickness and absence have also had some impact on that. And as I explained earlier, once you take those factors into account and you factor in the notifications, inquiries, whistleblowing, safeguarding inquiries that we've got to monitor and ensure that are being picked up, that workload spread amongst a smaller number of people has an impact in terms of the amount of time that they've got to do inspections. So we're very, very conscious of all of those factors, looking at how, exactly as Ted has said, what can we do to proactively recruit into vacancies and to also predict those people. And folk have been fantastic, actually, in terms of saying, well, I can retire at X, I'm planning to retire at Y, and that is enabling us to plan for that in a way that we hadn't done previously, and also to look at our skill mix and to think about how do we look at the things that we're asking inspectors to do. Are there things that we're asking inspectors to do that somebody else could do, so that we free up their time to actually get out there and do inspections. So there's a variety of different things that the team are looking at, as well as using bank inspectors and to plug some of the gaps in the meantime.
Okay, are we happy to move on? Anything else on the performance report anybody wants to raise? Yeah, Pete, you go. Yeah, no, fine, thank you. So Jane, I don't know if you're phoning a friend at this moment, but...
No, well, thank you very much. I'm very pleased that Imelda and the team prepared the report, but they obviously trust me to deliver it. So let's see if I can be trusted. First up, and looking back over the year, I am very proud to present, I think you will have had copies of our annual report, and this represents hundreds of thousands of people's voices, and through Local Health Watch and up through National Health Watch. And I'd just like to make perhaps 2 points around that, leading on from what I hoped I was going to do when I became chair. First is about tone, and the second one is about intelligence. And the one about tone is how to make sure that all this evidence, all this customer feedback, some of which is complimentary, some of which is critical, some of which is actually full of rich seams of good ideas, how to make sure that people, providers, actually do listen to it. And we've worked our socks off trying to make sure that our tone has been one of helpfulness, development, we're here to help. And I think you get a sense, I think, from our annual report that more and more people are taking up the evidence. In fact, providers are now asking us for more evidence. So I think that's a really a great thing. And there's a role for Healthwatch in helping with that communication. I was at a meeting in Hammersmith the other night, and the chair of the local campaign for the hospital was saying, oh, thank goodness, here we can have a conversation. It's all in plain English. We can understand what you're talking about. So we are very keen to make sure that people have their say. Doesn't mean that we don't also hold their feet to the fire when we need to. We had one local authority recently that was having problems in its attitude to commissioning, and we were absolutely straight down the line, said this will not do, and they came back and they said, okay, yes, we agree. The other point was about intelligence. When I came on as chair, I said I wanted to have a cobra. I think it was a Judi Dench moment. And we have indeed got an intelligence system now, which I'm proud of. And we've got a little team across there who are constantly combing and looking over what local Healthwatch are doing, what's happening elsewhere, and making sure that our offer to local Healthwatch, our CRM system, is as good as it possibly can be. It's getting there. But the other thing that I've found, just talking to some local Healthwatch, is that they've got a lot more information that's not actually necessarily reaching us. I don't know why, whether it was... And actually, when I started talking to them, I found there was a bit there about trust. And, I'm here in the Midlands, why would I pass it to you folk in London, type of thing? So I spent a lot of time over the last 12 months going out to local Healthwatch, talking, hopefully gaining trust with Imelda, with the team, and there's some really good quality people out there, the research teams out there. So I think we're really starting to sort of get a grip on the intelligence. We absolutely, when you published your the CQC State of Care report, our evidence absolutely supports what you're saying. I think our unique contribution is to provide that sort of practical level of detail that enables people in the service to go, that's what the problem is. So recently we looked at we looked at emergency readmissions, and everyone, you can see there's a bit of an issue. But what we found when we really, really looked at it was that it's in the first 48 hours. And then if you pass that back to people, they go, oh, right, okay, let's have a look, see what's happening. What are the issues? So I think that's where we make our biggest contribution. And looking forward, one other thing, I'm busy recruiting at the moment for new members of the committee, so applications have closed. And we had 400 applications. I was delighted, because I think that's a great reflection on the Healthwatch network that so many people were keen to come and help. Looking forward, we are preparing our strategy for the next 4 or 5 years and going out to people and saying, well, what do you think? How do you see the future? And it's interesting, because talking earlier about the pressures on the system, actually people are very keen to take control of their own health. Whereas about 4 or 5 years ago, when we were asking people, they said, it's almost Uriah Heep type levels of humility and gratitude to the NHS and wouldn't dare question it. Now they're a much better place, it seems, when they want to take control, they want to be involved, they're up for it, they recognise all the pressures on the NHS, they don't want to add to them, they really want information that will help them stay healthy, but when things go wrong, they want quick access to the healthcare. So we're talking, and we're going to take forward our strategy, and we will be bringing something back, hopefully to here, very early in 2018. So that's the story from Healthwatch.
Great. Questions? Jane, I had one for you. You talk in the report about the Healthwatch network, but I couldn't get any sense from the report whether that network is static, whether it's expanding, whether it's contracting. So what is happening around England?
Well, under the statute, every local authority has to have a local health watch, so there are technically 152. What is happening is that we're given the well-known pressures on local authority funding, and also the changes in the system where people are operating on a bigger area, that local health watch are coming together. They're either coming together as an entity, one commissioner has got several local health watches in their stable, or they're working more closely together so that you're going to look after this issue and you're going to look after this issue. So in answer to it's static. I think it's there is a lot of churn out there. There are challenges with funding. But we're just about to write to the Secretary of State, as we are asked to do each year, with the picture of what is happening out there. Overall, the system is in good health. The challenge for us, though, is to make sure that the quality of the best is the quality of all.
I probably didn't phrase the question very well. My sense is that there are some local health watches that are incredibly active and some that are not quite so active. So it was more around the level of activity rather than the existence of something called Health Watch in a particular place.
Yes, I'm so proud of Health Watch that I find it almost difficult to say no. There are some that aren't doing very well. Some of the smallest ones are as active as anything. I mean, you went to Rutland or Darlington, or of course a great anomaly is Manchester. Manchester has a grant of like £85,000, or funding of £85,000 for the whole of Manchester, the city, and yet they are. There's sort of a David and Goliath-like ability to really get a grip on what's happening in the local system. So I haven't come across. I know there will be in the normal distribution of outstanding, doing all right down there. There will be some. And we have a team of regional people who are out there all the time making sure that that they are as good as they can be. But we really rely and work very closely with local authority commissioners who, after all, have the final responsibility on getting that sort of quality service. And they seem to be very keen and very happy. We do quarterly, biannual training sessions, and they are very keen to work with us to make sure that the standard is good and they are all as active as they should be.
Thank you. Anything anybody else wants to? Ted?
Jane, to what extent are local health watch involved in development of new models of care, STPs, ACSs, etc.? I mean, the patient voice is going to be so important in those. Do you think it's getting a strong enough voice?
Good question. Well, going back to I think it was South Yorkshire, where they've got a big, they've got an accountable care system coming in there, and I went to talk to some 110 local trust governors the other day, and they were all very, very aware of their local health watch. And elsewhere, Yorkshire focus at the moment. West Yorkshire, likewise, they were the health watch where one local health watch is tackling this bit, and one is they've got themselves into a team. Manchester, likewise, you should probably know better than I. Devo, Manc, the Manchester Health Watch. Again, I was addressing them the other day, and they've got almost a new brand, Health Watch in Greater Manchester. And they really are working together and getting a grip. There was, probably this time last year, if you'd asked me, I'd been sounding a bit more pathetic because there was a sense in which local health watch were trying to work out how to knock on the door and make their voices heard. But I'm hearing much less of that now, and I do think that they are getting much more of getting their voices heard more. It was marvellous for us that on the list of priorities, they put engagement first of all, and we've been working on that ever since. One local health watch, I think it was down in Dorset, Martin, was saying that he couldn't get himself heard, so he decided to publish a sort of list of 5 or 10 principles of good engagement and say across the media, I'm going to judge you guys by how you do this. He said, I had phone calls from all the local providers in the next week. So there are ways and means of doing this. I come back to my David and Goliath analogy. There are some very canny people out there in local health watch.
So Jane, Imelda clearly didn't entirely trust you to do this on your own because she's now arrived. Jane was so pleased that You trusted her to do it on her own.
I trust Jane entirely. I just realised I don't know how to know when the point is to come in. I thought somebody would come and knock.
I'm sorry.
Because there's usually somebody outside, but there isn't today.
I apologise. It's obviously our failure. Anyway, Jane's done a great job in your absence. If you weren't listening, Lewis looks as if he wants to ask a question, and then I'll give you a chance. If not that you know what Jane said, so it's a bit hard to say to you. Is there anything you want to add? Because you don't know what she. But if there's anything you particularly want to say, we'll give you a chance in a moment. Lewis.
I'm sure I should know this already, but to what extent do you engage with people who use or would want to use alcohol and drug services?
Melda, you came at just the right moment.
I don't know the exact figure, and I can certainly send it through to you. But a number of local Health Watch do look at the types of services that there are and people's experience of it. I can't tell you off the top of my head how many of the 152 do, but I can dig that out for you.
I suppose I was thinking you had mentioned that next year mental health will be a theme. Obviously, alcohol and drugs are not just about mental health, but that's an important issue for mental health. And a lot of concern at the moment about the way in which alcohol and drug services have been rather separated in the way that they're commissioned from mental health generally. And it just would be a very useful source of information, I think.
We're still scoping the piece of work that we want to do on mental health, and perhaps we could have a conversation with you in those early scoping days, because there's so much. I think there were 36 priorities were thrown up from the local Health Watch experience, and so we've got to really decide at what angle we come at it from. But perhaps, if you wouldn't mind, a bit of your time, because I think that's an important issue.
Robert.
It's really encouraging that so many people contact you or in one way or another, and you get the information from them. Is there any, rather following on from Lewis's question, looking at the numbers in relation to the hospital care section and the mental health services section and so on, you there state specific numbers who've informed your report in that section. What surprised me slightly was that you actually have, I think I'm right in thinking, more people talk to you about primary care than hospital care. And I just wondered how it breaks down between the various sectors. That's the first question. And just developing Lewis's point, how you reach out to vulnerable groups generally, including mental health and people who may indeed not be the people who are forward in coming, who easily come forward with their concerns.
It is quite interesting. The public tend to volunteer a lot of information about primary care. And some of that is about access to care, access to primary care services. That tends to be it. They are also quite satisfied once they get the services, but they tend to talk about it more than other care. And I suppose it's because it just makes sense. It touches more of the population than those who use hospital care. A number of Health Watch, I think, have traditionally found it easier to engage with hospitals because they're buildings and they're there, and so a lot of the relationships have been built up there, and they've made a concerted effort to build relationships across primary care as well. I think, personally, when we're talking about more vulnerable groups or hard-to-reach groups, I think it's one of Health Watch's greatest strengths, to be honest. They get right into communities that would not be part of ordinary conversations with health or social care. And they run specific pieces of work, like with the Gypsy Traveller community, with sex workers, with drug and alcohol, right into places where homeless people are. So they bring that sort of richness through. We heard a great presentation from, I think it's Leicestershire, who have done very specific work about engaging with the Somali community on a very isolated estate on the outskirts of Leicester, and really brought them in and are also building up the advocacy within those communities so that they help others. And there's other examples of that in Camden. Camden Health Watch has done some brilliant work with Bangladesh community and built advocates within that community so that they can help things around breastfeeding and accessing services, those sorts of stuff. But I actually think it's one of the unique bits that we should be pulling out more and talking about more.
Good. So Jane was waxing lyrical about the progress you've made in the last year. The report bears that out. Is there anything you particularly wanted to say, say in the ignorance of everything else that's been said so far, Imelda, or are you happy to leave it?
Just one thing, and this is something I'm very proud of. My first meeting here, I was asked, are you doing anything on social care? And we're doing a lot on social care, and I wanted to highlight that. And just in the last few months, we've produced 2 reports on social care, one about people's experience of living in care homes, and another report on people's experience of domiciliary care. And when we move on to mental health, the social care aspect of that will be a big plank of work that we'll do.
Thank you.
Yeah, you made somebody happy today. Great. Jane and Imelda, thank you very much, and thanks to your colleagues both at Health Watch England and around the country. This is very good. Thank you. So, it's a terrible cliche to say that staff are our greatest asset, but actually in the case of CQC they really are. We could not do any of the things that we do without the incredibly good staff that we have. But I wanted today to just take a moment of the board's time to introduce Paula Mansell, who has got the Recognition of Outstanding Contribution Award this year, the ROC Award. And it's just fabulous what you've been doing. Paula's role is to lead on all kinds of sector integration work and on developing our own understanding as an organisation about how services are integrating and how we will then respond to all of that, regulating new models of care, a whole pile of things which are really, really important to us. But that isn't why she got the ROC Award, but it's a really important thing to be doing. The ROC Award came because of the work that you did on the Cornwall Care in a Place, which we've talked about elsewhere in the board. And that was a pioneering, in a sense, piece of work for CQC that then flows into a lot of the other local area work that we have been doing. And I just think it's fantastic that you took that on, developed it, and did everything else. So I wanted to congratulate you. I would have liked to have been handing you an award, but you've already had it, so all I can do is embarrass you by can't give you anything else. But just on behalf of all the board, thank you very much for all you do, and long may you continue to do it for us. Thank you very much indeed. And I said before we started I would embarrass you. If you want to say anything, you're welcome to. If you want to just sit there and bask in the glory of the applause of the board, that's absolutely fine. If you are going to speak, you need to just go and grab a microphone, though, so the whole world can hear you, not just the people in the room.
Thank you very much, Chair. All I would really like to say is that it's part of a much wider piece of work, looking at how we look at evolving and different new models of care. And that it was very much a piece of teamwork, part of the integration team and the work that they're doing, but also the hospitals team, the PMS team and the adult social care team. The enthusiasm and commitment to take on this new and very different piece of work was amazing, and it was great to work as part of that team. Thank you very much.
Done in the best Oscar acceptance speeches. Thank you very much again. Stay with us, please. So, for the board, is there any other business anybody wants to raise? If not, we'll end that part of the meeting, but that leaves us with not a lot of time, I'm afraid, but some time anyway for questions and so on from members of the public. And I'm going to take them in the order in which they reached me. And Bren, you were first out of the trap, so would you like to go and take a place, turn the microphone on, say who you are, and then say what you wanted to say?
Okay, David. I'm Brett McInerney. I just volunteer in the local community in Gloucestershire, and in discussion with Peter before this, really, I wanted just to share with the board something that I think I brought to the board maybe about a year ago about actually how arm's length bodies can better harmonise their approaches to engagement, in particular with neighbourhood and community groups. In July 2016, I had a meeting with the Minister. Thereafter, I had meetings with various chief execs in terms of David Beam. I think his approach was, I'm very relaxed about this, Bren. And Chris Day has got it, hasn't he? And therefore, thank you, and we'll go on, really. On the Tuesday, the 7th of November 2017, we delivered that national pilot down to a series of community organisations. I think in terms of voluntary community organisations, there are about 100. The discussions covered 8 different sites in Gloucester. Imelda was very really welcome and Lorna pleased to be absolutely involved in that. In terms of representation from Care Quality Commission, Paul Corrigan was there, as was Chris Day and a member of Chris' team, and I'd like to offer through Maltreed our thanks to Chris for that absolutely dedication, commitment, and most importantly representation of the vision of CQC, really. What I was very clear about at the start is I don't want any money, I don't want any project plan, I don't want any structures and systems. Of course I want to be accountable and whatever, and never do anything totally blind and whatever, really. But that's how we did it, really. And I think I could capture some of that through Duncan Selby's Friday message, really, which I think his end quote was, during the day people talked about the importance of hearing each other more, recognising the smaller charities find it hard to compete for resources with the bigger ones, and need for searching practical solutions that would help with this. On January 2018, Peter, Paul and Chris Day will join, I think at the moment, 4 Lords, 2 Ministers, 22 national bodies, and probably around 60 smaller neighbourhood community groups that were part of that discussion. And it really featured on 3 things, really, is can arm's length bodies better harmonise their approaches when they're engaging with community and neighbourhood groups? Secondly, really, what is their offer when they come down and have that conversation, for example? And thirdly, really, which again came out very, very clearly on the 7th of November, which in fact we held the event at the police headquarters. We had the Chief Constable open it, so often that tends to happen. You have the Chief Accountable Officer of the Clinical Commission Group or the lead for the Council or whatever. My decision actually really that we need to go wider with our conversation, involve greater partners really. So the Chief Constable, Rod Hanson, opened it and whatever. Duncan Selby, as I've agreed, is taking a national lead for me on this really. Very, very clear about that. And Duncan actually closed it with those 3 comments really. So I just volunteer in the community. That's nothing more, nothing less and whatever. But what I can say really is, again, when we provide platforms and the environment and the supportive aspect of this, we can do it, and that will be clearly identified and discussed with the ministers, with Peter, with the national bodies, and more importantly with those 60 community organisations who are actually part of that initial conversation. Not always usual or whatever really, but again, let's take this a very, 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 very proud moment that it can happen, and more importantly, and whatever really happens with visionary and willing people in organisations, it will always be about people.
Bren, thank you very much. I'm really sorry, Bren, I couldn't be there. As you know, I was already committed to various meetings in Yorkshire, including with the chairs of the various trusts in Yorkshire. But Paul Corrigan, who was with you on the 7th of November but isn't actually here this morning, did send me quite a long email afterwards just saying what a great day it was and congratulating you. I'm sure he said it directly to you as well on what you achieved, and I'm certainly looking forward to the 31st of January, is it? Anyway, whatever the date is, it's safely in my diary, so I look forward to that. And thank you for what you do, and thanks to the people who are doing it with you in Gloucestershire. So that was really good. Robin, you were second to notify me of a question, so please have a seat, turn on the mic, say who you are, and ask your question.
Thank you, Chairman. Robin Pike, Hertfordshire Health Watch. Could I just add to what was discussed earlier? Hertfordshire Health Watch is certainly very active. Their voice is certainly heard, particularly with difficult situations that arrive with the CCG seeking to fail to commission certain services that are very valuable to the community, and Health Watch is able to express the opinion of people. The question, Chairman, relates to the digital and intelligence strategy, which was discussed at the October meeting. And I'm asking whether CQC as a government agency might benefit from collaboration with other government agencies that already have a lot of experience in this field, particularly with intelligence gathering. I should say that I come from Cheltenham, and I grew up about a mile from a government agency that has a lot of experience in this field. And then in particular, again, following the October board meeting, Professor Baker mentioned the report on UCLH, which is available, published on CQC website. I was unable to access the full report. Whether it might be encrypted, I'm not sure. My own IT skills may be perhaps a little lacking. I'm only a chemist. But whether the development of the digital and intelligence strategy might have an impact on the website.
So the short answer to the question is yes, but the longer answer will come from Malta.
Thank you, Robin. So on the first part of your question, how we're working with other government agencies, the first thing to say, of course, Pete Sinden is a joint appointment between us and NHS Improvement. So we're already working very closely with the other health and where relevant care sector organisations, including NHS Digital, NHS England, and of course alongside that also much more widely with the Government Digital Service, which oversees all of the digital development across the public sector bodies. We're also reviewing how other government agencies work as part of that. And have those conversations. I would add that even more important is the user research that we're doing right now about what it is that the audience and users of CQC services, whether that's people who use services, whether that's the services that we regulate, or the wider public, how they use those services and what that means for how we design all our digital services, whether that's in terms of information collection or information sharing. Which brings me to the second question about what the website will look like, or what it can look like in the future. I can't give the answer of what it will look like, because right now we are in the process of doing the user research and understanding of what the different audiences of the organisation are looking for, particularly from our website. You highlighted the point about the search function within it. You won't be surprised to hear that that's one of the findings from the user research and something that we're aware of, but obviously have that now in much more detail in terms of what that requires to find information, but also alongside that, that we should have a much clearer separation of the different audiences and how we share information, whether that's services who want information about how we regulate them or what it means to register, or whether it's members of the public looking for information about a particular care service, or indeed the wider public. So we're beginning to have that insight and those findings now to begin to design the website. So it'll address the points that you mentioned, but I couldn't tell you now what it will look like, but we're definitely in the course of doing something about it.
If I could just add that intelligence for us isn't just the sort of secret intelligence that spooks and others will have. So the private sector, the commercial sector, does an awful lot of gathering of information, which is intelligence, but of a different sort. And that intelligence and understanding how they gather it, I think, is going to be equally important to us as anything that is done by other government agencies. So there's more to say. We are talking to the other government agencies, but we also have a lot of experience of what the private sector have been doing. So we're learning from them as well.
Thank you.
Thank you. And David, you were the next to reach me, so the floor is yours, David.
I'm David Hogarth. I'm from an organisation called Neighbour Care St John's Wood and Maida Vale. We come across a lot of care, both care homes and home care, in the course of our activities. The question I wanted to ask was picking up on, I think, a promise made in June or July that there was going to be new guidelines on the use of technology in care. As people will know, I think I have a particular interest in the use of surveillance, particularly for the CQC, to make it easier for you to understand exactly what is going on, to flesh out what you're doing, to confirm or not confirm suspicions you may have. And there are, I used to say, cameras, cameras, cameras. Now I've sort of gradually realised that there are different kinds. There is CCTV, which is put in, of course, by the provider at one extreme, and the other hidden cameras, which the provider knows nothing about, but is usually put in by a suspicious relative. In between, I become particularly interested in two-way audio cameras, which are actually put in by not by the home or by the provider, but by relatives, with the agreement of the home, so that the relative, not so much a spy camera, as that the relative can collaborate with the staff in their care. And it is also a good thing because people in the government have been saying that it would be good if relatives played a little more part in the care of their older people. And this does give an opportunity to relatives to do this. So what I'm hoping is that when this guidance comes out, there will be this two-way audio possibility will be taken into account. Thank you.
Andrea.
Thank you very much, and thank you, David, for the advance notice of the question. So, as you know, we published in February 2015 information for the public, and we had previously published information for providers around the use of surveillance, and we're coming to the 3-year anniversary of that. It strikes me that time is passing very quickly because it doesn't feel like 3 years since we did that. So we are committed to updating that information, both for providers and for the public. And what we want to do is to update the document so that it does better reflect how technology has changed since we did it 3 years ago. And I think you're absolutely right. There's a variety of different mechanisms. In fact, I know of some very good services that are using auditory monitoring, which is actually having a real positive impact on the quality of care and the quality of experience of people who are living in their services through the reduction of falls, for example, in different ways that they had not necessarily anticipated, but has been a real positive impact of that. So we're going to look at it in a much broader sense so that we can take those things on board. We've been slightly delayed because, as I think Ted mentioned earlier, some of our plans for this year were knocked a little asunder by the timing of the general election, and that kind of knocking on impact in terms of when we started our next phase of regulation and the work that we needed to do for that. But we are starting that process. In fact, we're having an initial conversation with the Adult Social Care External Co-Production Group tomorrow, on Thursday. So we are starting that process. We hope to be able to bring something out in spring of next year, and certainly would be looking to engage you in the co-production that we will do on that, David. Thank you.
And David, you are 100% right. There's a lot of really exciting technology out there, and it's understanding it and understanding how it can be best used. So thank you for raising that. And I'm afraid I wasn't paying proper attention to the clocks. I should actually have said we had to stop before you had your question, David. So but we are out of time, so I apologise to anybody else who wanted to raise a question. But that is it for today. Thank you all very much for coming. Thank you.